Good afternoon and welcome to Wound Care Without Walls, practicing wound care in a virtual world. My name is Brenda Viola. I'm the Marketing Director for Medical Solutions Supplier. We supply Lympha pneumatic compression therapy. Also on the panel today, you may not see him right now, but Eric Ansart is the president of Lympha and he'll be here to help moderate today's program as well. And we'll introduce our panelists in a minute. Before we go any further, I want to say this first. Thank you. We are in unprecedented times. That word seems to have been overused, but there's no other word for it. Unprecedented times, and social distancing has upended our way of life and how we do business. So thank you for those of you who are on the front lines, continuing to care for people however possible. And we hope that these webinars empower you while we are unable to in-service you in person. And we at Lympha are very proud to partner with you. After all, we are all in this together. So without further ado, there's a little bit of business. We must offer a disclaimer, which you can review, just simply stating that these are unprecedented times and we're giving you the best information we have at the moment, and use your good judgment when you apply these bits of information that we're offering. Our panelists, our esteemed panelists, are Dr. Scott Covington. He is a leading general surgeon with an emphasis on wound care and hyperbaric medicine. And Karen Ashforth, those of you who joined us last time know her well. She is a board-certified lymphedema therapist with a wide range of expertise in the treatment of lymphatics and the use of intermittent pneumatic compression. Our agenda today is robust. Dr. Covington is going to review the pathophysiology of venous leg ulcers, current treatment regimens, and how COVID-19 is impacting all of this. And Karen Ashforth is going to give an author's perspective on the research involving Lympha protein absorption, tools for home monitoring. I say let's get into it. And Dr. Covington, my first question is this: how has the COVID-19 world impacted the wound care community?
Thank you, Brenda. Pleasure to be here. And again, pleasure to be with fellow clinicians and those facing the challenging times we have. I remained active in 2 wound care centers here in Jacksonville, Florida. And as you all know, as we appreciate, healthcare, wound care remain essential services. So our clinics are open. We're seeing patients. The volume has diminished a little bit, though, and understandably in regard to the concern around the virus. So we're still seeing patients. We are providing the necessary care, but we are getting cancellations for patients who either physically can't or emotionally can't envision themselves being in the wound care center. So care goes on, but the challenges go on as well. Well, speaking of challenges, as Brenda highlights, we truly are in unprecedented times. And we've never faced this. I certainly have never faced this clinically. I would assume that you haven't as well. And so we've got to think differently. I think as a community of wound care providers, of lymphedema therapists, we've got to think differently about what our patients need and how we can deliver that care more consistently and choose venues for the patients that meet their needs at this challenging time. So this obviously reflects our observations, those on the call, but also from the AAWC, the Alliance of Wound Care stakeholders. So next slide, please. Lee Rogers, representing the Alliance of Wound Care stakeholders, represents the similar view, and quite simply that we are in these challenging times, and it's not only reasonable but appropriate and sometimes life-saving to manage wounds in different places. If we're patient-centric with regard to our consideration, if we can avoid those unnecessary ER visits and hospitalizations as a result of a deteriorating wound or a cellulitis or some clinical challenge, then we truly are doing the patient a greater service than ever. So next slide. So I want to spend time really thinking about a couple of different etiologies, and more specifically, venous leg ulcers and the edema association with that problem. We know that venous leg ulcers are the most common lower extremity wound seen in the outpatient center. So we realize the impact with regard to the number of patients. We on the call who take care of these patients, and I know many of you do, realize the clinical challenges, the necessity for frequent, appropriate, aggressive, patient-centric, and driven care to get the best outcome. Obviously, DFU is a major clinical problem for our patients as well. We know our population in the U.S. is somewhere around 10% or 15% of patients, Americans, are diabetic. And some quick math around that would tell us that 1 in 4 develop a lower extremity wound at some time in their lifetime. And so we see the tsunami, if you will, the ongoing tsunami of both of these clinical challenges in this time that we face together. So next slide. Let's think about venous leg ulcers if we could. And again, this is a review for the vast majority of you on the call. We know that these wounds are obviously lower extremity wounds and typically occur in what we describe as the gaiter area, somewhere between the mid-calf to the heel. The wounds are shallow, they're irregular. Exudation, wound exudation, weeping wounds are very common and very problematic, and these are painful wounds. Patients are suffering consistently and regularly as a result of these clinical challenges. Let's go to the next slide and dig in a little bit on etiology. We know, in essence, we're talking about a valve problem, right? It's a mechanical problem with the vein. And we know that the blood flow typically is unidirectional in a normal vein from south to north, and we prevent backflow of blood by the bivalvular structure of the veins in our legs. When these valves no longer work or don't function in a fashion that promotes unidirectional flows, you can see in the upper right-hand corner, then we result in, or we see clinically, retrograde blood flow. The blood doesn't leave the leg. This leads to venous hypertension, or an increase in the blood pressure in the venous system within the leg. Well, our veins really aren't designed to manage that level of pressure, and we know that, and they leak. They quite simply leak fluid, and they leak what's inside the blood vessel to the outside of the blood vessel. Clinically, this occurs when we see red blood cells leak out of the vein, and they break down, much like a bruise would break down, creating that typical brawny or brown stained or bruised, almost a bruised type appearance of the leg. Lipodermatosclerosis likewise occurs in association with the combination of fluid loss or plasma loss, plus the activation of white cells in the extravascular space. White cells don't like to be outside of blood vessels. It tells them, hey, we've got an invader, an intruder, and they release a variety of collagenases and elastases, which can be very traumatic to tissue. So it's the combination of acute and chronic inflammation that ultimately leads to tissue injury and the development of a wound. So next slide. That lays the foundation, if you will, for why we develop venous leg ulcers. Let's take that step or take that consideration one step further and think about the role of edema and how we manage edema clinically in the setting of venous leg ulcers. We know that there is a delicate balance at the capillary level between filtration or loss of plasma outside the blood vessel and then reabsorption. And there are approximately 30 liters of filtration followed by 27 liters of reabsorption on a daily basis. So we manage that very well dynamically. We know that the lymphatic system is critical to manage the overage or the overrun or the imbalance of fluid to keep us in a state without edema and a well-functioning limb. We know that it's pretty easy to perturb that balance. So venous hypertension, as we talked about, can lead to, in essence, a backflow issue. So contributing to the worsening of the lymphedema and then primary lymphatic disease as well. I know Karen will comment on that in just a couple of minutes. So let's go to the next slide, if you would. Okay, so how do we take care of venous leg ulcers? And again, I'm respectful for the notion that I'm really speaking to experts in the room, and you guys have been managing these wounds classically for a long time, and you get it. But let's just remember that there's some foundational activities, some thought processes that we need to think about in managing venous leg ulcers. And the first is compression therapy, right? We're counteracting the force, the distensible force of these diseased veins. So using a multi-layer wrap or short stretch or a Uniboot type wrap or a Duke boot type wrap. And then very importantly, pneumatic compression systems that we'll hear about today are foundational in managing not only the lymphodematous concerns, but the venous hypertensive concerns as well. Appropriate and well-timed debridement, dressing selection application to manage the microbiome of the wound, to manage the excessive drainage we see in these patients is critical as well. We know there are various medications that are beneficial, pentoxifylline or Trental, doxycycline, there's horse chestnut seed extract, aspirin on a daily basis, and a variety of medications that are beneficial as well. And then once the wound's under our control and we've managed the edema, we think about closure opportunities, either with autologous skin grafting, maybe a cellular-based tissue product, or a placental product that are commonly used as well. And then lastly, dealing with the underlying venous issues. So it's endovenous closure to manage the superficial venous incompetence that is fueling these underlying wounds. So let's go to the next slide, if you would. Okay, so we understand what we're taking care of. We understand the pathophysiology of edema and venous leg ulcers. So where are we doing these things? Well, we know right now that there are a variety of programs, outpatient wound care centers, that involve a variety of different skill sets. Perhaps even on this call today, we have vascular surgeons, podiatrists, we have WCN nurses or nurses with advanced training in wound management. We have lymphedema therapists, physical therapists who understand and are critical in proper wound management as well. So limb salvage program, points of care to include not only wound care centers, but inpatient service, skilled nursing facilities, LTACs, even burn centers are getting in on the wound space as well, and then home care, right? We only see our patients in the wound center a day or so a week at most, and these patients need more frequent care. So involving our home health partners is critical as well. Next slide, please. And so we get it. We realize that what we're doing, what we're delivering actually works. So wound care centers are becoming very popular. If you look at 2003 to 2017, we see what I would perceive as an appropriate understanding and need for advanced wound care of this type that occurs in wound care centers and in the venues that I've previously mentioned. Next slide. But here's the challenge, and we know this interesting fact from the standpoint of looking at large patient populations. We know demographically, if you look at a disease segment of our population and tied to their age, that we should be seeing a significant increase in the number of patients with venous leg ulcers and diabetic foot ulcers in our outpatient care venues. And the reality is we're not. We're only seeing about 10 to 20% of the treatable or the allowable or the addressable patient market within these points of care. And the question is why? And I think, we've begun the call around the COVID challenges, but we were seeing this before COVID as well. So let's go to the next slide as we think about the deficit and understanding. And as we do so, let's think about the cost of what we're talking about. Let's think about the cost of what we're talking about in terms of success and failure. So here's a very interesting study looking at the real cost of venous leg ulcer management in a vascular practice in Boston. This was Dr. Ira Frady and Tom O'Donnell and his group, and they looked at 84 patients over a 6-month time period. And looked at the average cost of treating patients with venous leg ulcers, $15,000. When they were successful, the cost was $10,000. 17 of the 84 patients, though, didn't heal within that 6-month time period. And I know you, if I know you and you're like me, you've got those patients that you've had for well longer than 6 months. And in point of fact, they're still not healed. Well, the unhealed patients in this study were 3 times more expensive than the patients who healed. And the cost contributing factors were obviously outpatient facility fees, visiting nurse costs, and then inpatient management. Inpatient management is very expensive, and it's really expensive now as we think about the consequences and the challenges in the COVID world about putting these patients in the hospital house, and actually providing care. So not only is it very expensive, it's very risky, and I think we need to be thinking about other opportunities as well. Okay, so I think if I've done my job, I've laid out the problem, right? The problem is we've got a very difficult challenge on our hands. Managing complicated venous leg ulcers and diabetic foot ulcers on a regular basis is a major concern and a major opportunity for many of us. These are complex, highly morbid patients who require advanced products and advanced services, and individuals who understand the needs and the timeliness of care to get the best outcome. But here's the challenge. Right now, we're still managing patients according to venues, right? I think we're still asking the patient consistently to go to a place and see a provider, go to a place and get a thing done. You know, you've got to arrange transportation. My parents passed last year, but I will tell you, my dad bemoaned regularly about being an older patient was a full-time job, because either he was going to the doctor or taking my mom to the doctor. So we're really adding a significant burden to our already challenged patient population in the way we're managing care currently. Well, let's go to the next slide. So I think I've elucidated care is driven by what we can do to the patient. So we're paid, unfortunately, right now in the fee-for-service world based on the number of things we can do for a patient and the number of times we see the patient, and that drives costs to the system. And I think we could argue provides questionable incremental value to the patient's experience along the way. And in point of fact, we're really talking about not only the patient, but those who care for the patient as well. So it's primary care providers. It's us on the call who have a unique interest in wound care and edema management, specialists, home health, and wound care centers. So I want to go to the next slide, and I want to think about what do we want to be? How can we think about a better solution? And here's a question that I would propose to you. Can we bring appropriate, well-timed care to the patient in a patient-centric fashion and not a venue-centric fashion that utilizes tools and resources, that utilizes our time and, more importantly, the patient's time to drive the best experience, to limit supply costs, to reduce the episode of care duration, to reduce recidivism, right? These patients are always failing. They're coming back because we haven't done our job, or they haven't done their job, or their disease has manifest in a different way. So that's the question. And I would suffice to say that there isn't an answer, but I would ask you to begin to think with me, to begin to think about what opportunities might look like, not only in the COVID world, but in the post-COVID world. Are we going to do things differently or think differently about how we manage our patients, given the information that we have now and the high likelihood that we'll have challenges of a similar nature going forward? So this slide sort of depicts some thoughts that I've had around how we could utilize telewound care as a valuable patient-centric tool and pull in others to support the process, but all the while making the patient the focus of our care. So you can see weeks laid out here. So week 1 would be where the wound care physician or the expert in wound care actually visits the patient's primary care physician with the patient there, either scheduled or de novo, evaluates the patient, has an exchange with both the provider and the patient, and assumes or manages the patient going forward. Week 2 could be a virtual visit. So at this point, the patient may not require a physical examination. It could be a check-in. It could be a skin tear. It could be something minor where, again, we have the opportunity to manage distantly and then keep everyone in the loop with regard to the reporting process. Week 3 might be an opportunity to have home health, or maybe home health has already been partnering with the care of this patient. So having a virtual check-in between the provider, the wound provider, the home health team. Maybe it's time to enroll a specialist to provide an additional service, or get on the schedule of a specialist without actually having to have seen that specialist or waited in that specialist's waiting room. Week 4, where we have the opportunity at some point to have a face-to-face encounter with the patient. Maybe this is the first time they come to the wound care center. Maybe this is the first time they need an aggressive debridement. Perhaps we've used an enzymatic debrider or some other product along the way to facilitate an effective intervention at the right time for the right patient in the right place. Next slide, please. I'll summarize my comments or conclude my comments with this slide. This was a recent publication by David Armstrong and Larry Lavery, Warren Joseph, and some others from the American Podiatric Medical Association. And I was very pleased to see this, in that there's an understanding about the priority and the triage, if you will, of patients in our COVID world. So suffice it to say, this slide says that for patients who have wounds that are clinically stable or are guarded and perhaps maybe serious, let's try to keep those patients out of the hospital. Let's try to utilize telemedicine. Let's utilize home health. Let's utilize the safety of our own offices, provide necessary care, and then only when possible, advance that patient's level of care into the hospital setting. And so I think we all think this way, but I think now in the COVID world, and hopefully we're coming out of that to some degree, and then going forward, do we need to think differently about who's taken care of, where they're taken care of, and then utilizing our tools and resources and our venues in an appropriate patient-centric way. And with that, I will pass the baton.
That was an awesome presentation, and I'm sure there are many questions out there. I want to encourage those of you that are attending the webinar. There is a Q&A spot on your screen. Feel free to type in a question. At the end, we will get to the answers as best we can. And I also want to remind everyone too that if you're on this recording today, you're going to get a copy of it tomorrow. And so I think that was a lot to digest, but I think your point of this COVID-19 situation nudging us in a direction that maybe we would have stalled at if not necessary. Necessity is the mother of invention, and a new model of taking care of patients. That's what we're talking about here today. And I'm going to make the transition to Karen Ashforth now, who is going to share with us some exciting research. So Karen, take it away.
Thank you so much, Brenda. Hello, everybody. Just a little bit about me. I've been a lymphedema therapist for 17 years and have been practicing at an outpatient hospital-based lymphedema clinic up until 3 weeks ago when our clinic closed down due to quarantine. So I have been practicing by doing telehealth visits and home health visits, and it's really stretched my practice in many, many ways. So I'm going to start by sharing some research and then talk a little bit about some of the models that I'm using to deliver care in creative ways. So to start, we're going to talk about an interesting study that was done by Melissa Aldridge in 2016 using IC Green, which is a very innovative type of imaging that is particularly useful in showing the motility of the lymphatic system. So Eric, I don't know if we can animate. There we go. Yeah, so this is just kind of an example of, you can actually see the lymph moving through the vessels through this image. Very, very exciting. So moving on. This study, which I was very honored to be a part of, involved imaging healthy and unhealthy lymphatics. And this particular slide looks at a patient who had very profound blockages, a lot of lymphatic damage, and there was little to no movement of the lymphatic system in the leg prior to pneumatic compression treatment. So this just shows a clear sleeve, and underneath the sleeve you can see the injection sites that they've put black tape over, and then on the right you can actually see the movement that is happening while the pneumatic compression is active. Very, very exciting to show that when we look at, in this case, lymphopress pneumatic compression, we saw increased measurable lymphatic velocity and frequency and increased lymphatic function during and after treatment in all of the subjects. So I want to make a point here. There have been a number of studies using ICG and other pumps, but lymphopress is the only pump that has been shown to directly increase the lymphatic function in the treated limb using this ICG imaging process. So I'm going to shift gears a little bit and talk a little bit about some of the strategies that I've been using in my practice to treat uncontrolled edema. And I have a number of wound care patients in my practice. So how can we help people if we're not seeing them in person? And in the clinic, my German gold standard of treatment is manual lymph drainage, compression, exercise, and skin care. But when we're dealing with people on a more remote basis, I find that I'm having to throw in a bunch of other things. So on the left, you see conservative treatment, which is compression, exercise, and elevation. And on the right, I'm also teaching patients remotely manual lymph drainage and talking a lot about risk reduction and skin care, how to track their symptoms, and then the use of lymphopress, which I feel really empowers patients to be able to treat their lymphedema at home in a way that is more profound than many other options. So moving forward, compression is critical. As Dr. Covington said, we need to be able to compress the leg to compensate for the venous function, and there's lots of options. If a patient is being seen at a wound center, they're often in a Uniboot or the double layer Coban bandaging. Sometimes if a patient can come to the clinic, they can learn compression bandaging, but that's a very difficult thing to teach remotely. Elastic garments are not always appropriate for patients who have wounds. So I have found that Velcro compression wraps can be a very, very good option for patients. And this just gives an example of a wrap that has a hybrid liner stocking. It compresses the foot, but it's very easy to put on over the lower leg because there's very light compression on the lower leg. And then the wrap itself is doing the job of compressing the lower leg. Very, very helpful for people who have venous leg ulcers. It really creates a better system for helping to move that fluid as the patient exercises and elevates their legs. So speaking of exercise, I find that it's critical to educate my patients in how the calf muscle is the big motor to pump both the blood and the lymph out of the feet and the legs, and how critical it is for patients to be doing ankle pumps, to be walking, that calf muscle needs to be engaged. And ankle mobility is often a factor for many of these patients. Sometimes they have almost frozen ankles and they're doing a Frankenstein walk. So we have to really get that ankle moving so that the calf can move as well. Also, breathing is very, very important for circulation. And there is a wonderful video that I'm hoping will be included with your email follow-up tomorrow, where my colleague Leslie Bell, who is a doctor of physical therapy and the owner of Timberline Physical Therapy in Vermont, she goes through and talks about all these things about exercise and breathing and even some simple self-manual lymphatic drainage. And I recommend that video as a very good tool to offer our patients who are at home. So other things that we educate I talk a lot about risk reduction in my clinic, in telehealth visits, at home. We talk about reducing the COVID-19 risks. And we also really want to look at cellulitis. I don't know how many patients I walk over to the ER or I send to their doctor because they have suspicious symptoms. So educating patients about the signs and symptoms and what to do is really important. Definitely having good skincare habits, being able to teach manual lymph drainage, and monitoring symptoms and home program becomes a critical aspect when we're working with patients remotely. I want to just offer to those of you who are unaware, the Lympha Track system is an excellent system specifically for lymphedema patients. It is a free app that patients can use on their smartphone, and it's easy to download. They can use it to enter their symptoms, what they're doing at home, and they can send the data to the provider so that we can track by charts or tables or raw data. How are patients doing? How are they following up? Where are they falling short? Where do they need help? So this really helps with many different things. The symptoms that can be monitored would be a patient self-measuring their circumference, looking at their skin color and pain level, measuring wound size, monitoring their weight, and history of falls. Home program aspects that can be mentioned would be their use of manual lymph drainage, their use of compression garments and pneumatic compression, and activity level. And to the left, you can see a graph, an example of how patients are using these tools. So shifting gears, I want to talk a little bit about what happens if a patient is doing conservative treatment for 28 days and they're continuing to have uncontrolled swelling. They may need bigger guns, and that's when I would suggest bringing in a LymphaPress pump. So the LymphaPress pump can give the patient more both decongestion and compression as they are doing the rest of their home program. And having a referral for LymphaPress after the 28-day mark for most insurances is often very appropriate. So as I mentioned, the LymphaPress provides both decongestion and compression. In a minute, I'm going to show you an incredible slide about cellulitis and wounds. I have found in my practice that this is one of the easiest modalities for patients to use at home to address swelling. And as such, it has a very high compliance rate. And certainly, as Dr. Covington mentioned, healthcare costs can run very high for people with uncontrolled swelling and wounds. So being able to decrease costs is key. This picture just says 1,000 words. And I was shocked to read this study that Mortimer and Roxon did a few years ago, showing that patients with lymphedema are 71 times more likely to develop cellulitis than those without lymphedema. And pneumatic compression has been shown to decrease cellulitis incidence. So this is a no-brainer. Patients come into my clinic and they have a history of repeated cellulitis. I'm going to be looking at what have they done, what have they not done, and would they be a good candidate for pneumatic compression. Patients with venous leg ulcers, as Dr. Covington mentioned, are a huge part of my lower extremity practice. And again, pneumatic compression really seems to be a very effective treatment for these patients who have been using compression for years. They've been elevating and exercising, and they're still having repeated incidences of ulcers. They are having chronic uncontrolled swelling, and pneumatic compression helps to manage that. So just to summarize, the advantages that I really see in LymphaPress, and I want to mention that I use a lot of other pumps in my clinic. Over the last 15 years, I've used maybe 5 or 6 different types of manufactured pumps. And I keep coming back to LymphaPress because what I'm seeing is, in terms of comfort, I have patients that have a lot of neuropathy. And if they are using a pump that has a long cycle time, that doesn't have much of a pause between the cycles, it can really hurt. And we have to lower the pressure down to where it's not really very therapeutic. So I've literally taken patients who have had pumps that are inappropriate for them because they don't have the flexibility of these settings of cycle time or pause time, and instead changed over to a LymphaPress pump because they have those options. And then related to that is the ability to do complete deflation, which is very rare in other pumps. And the advantage of a complete deflation is it allows the lymph to move so that when you compress again, it will move forward. So it is a very, very useful feature. Also, the overlapping chambers in LymphaPress help to prevent dermal backflow and reflux, and they mimic the short stretch compression bandaging that I use with patients. So I find that that is very, very useful. The LymphaPress appliances are very easy to put on, and for wound care, it's important to have an appliance that can be easily cleaned. Also, sometimes patients have a hard time putting on even wraps, and having an appliance that closes with Velcro, in my experience, I found that patients don't always close it completely, and so they're not getting the treatment that they should be getting because it doesn't compress adequately. Whereas with LymphaPress, you have a zipper closure and it inflates to fit, and it gives the same treatment every single time. There's also a wide range of pressure. Many of my patients have problems with fibrosis, which is a hardening or thickening of tissue. Many of my patients have high body mass. And in those two cases, you really need to be able to have the option of higher pressure in order to give an effective treatment. So that would increase the decongestive effect. So in summary, I would say that considering LymphaPress is a good option for many patients who just have continued uncontrolled swelling. And at this point, I'm going to turn it back to Brenda so that we can answer some questions.
We have some wonderful questions, and I want you to keep them coming. If you're in the audience, just type in the Q&A there. And I think I'm going to work my way backward because the last question we got in really dovetails off of how you ended. Clearly, not all compression pumps are created equal. And I have a question here from Nilma Santiago, who says she uses the LymphaPress in the office. And I think this would be directed to you, Karen, and also Dr. Covington, be on standby because I have questions for you too. She has seen great results, but why are so many therapists not using it or believe in pneumatic compression therapy? She had 2 patients that had received complete decongestive therapy before and were never even told about pneumatic compression. What would you say to that, Karen?
Oh, that is such a great question. And I'm going to just use myself as an example. When I went through my initial CDT training, at that time, almost 20 years ago, pumps were very different than they are now. And there was not a lot of encouragement around the use of pumps. It was really not something that was as accessible or available or as versatile as it is today. So I think that many of the lymphedema therapists just haven't been exposed to the usefulness of pumps as an adjunctive treatment.
So it's education and raising awareness, and opportunities like this really do help to shape that message. Nilma's previous question, and I'm going to read it verbatim because I don't want to mess it up. So she is a physical therapist, wound care and lymphedema certified, owns a private practice specializing in wound care and lymphedema in Altamonte Springs, Florida. Her main issue right now is that she has not had any new patients since her referral sources are not seeing any patients in the office right now. And I bet a lot of lymphedema therapists are nodding to that question right now. She only has 2 lymphedema patients at this time because she is the sole provider in the office and sees them on a one-on-one basis with the appropriate PPE, thus being able to follow the social distancing guidelines. CMS is not reimbursing physical therapy, telemedicine at the time, just e-visits for 7 days of patients that are already established. Therefore, she is considering doing this cash-based She's a strong believer in the need for lymphedema and wound care therapy now to keep patients out of the hospital. What would be your recommendations? I know there was a whole lot wrapped into that, but it speaks to how our business models have been affected by COVID-19 and how to continue taking care of people. What would you say to that?
Wow, that is such a loaded question, and there's so many facets to it. So just speaking from my experience, once my providers realized that I was still taking care of patients, the referrals continue to pour in. And that would be the first thing I would suggest to you, Milna, is that if you get in touch with your providers and let them know the options that you have for the patients. A lot of people are putting their lives on hold, but many of our lymphedema patients, they just can't afford to. The disease is going to progress, and if we wait, the symptoms are going to worsen. So that would be the first place that I would start. And it sounds like you're getting very creative in terms of thinking of different options for your patients. So that's fantastic. And I think I'm going to stop there because I know we have a lot of other questions to answer. And Milda, if you want to follow that up with another question, feel free.
Yeah, great. We want to go to Michelle McDowell's question next. And she says, as a lymphedema therapist, I feel the compression is so important, including the patient understanding the importance of this. Share your ideas on how we can do this sooner and more effectively. I feel that there is a need to address this earlier in the healthcare system to prevent progression. What are your thoughts?
Oh, Michelle, that is a great, great question. And again, I go back to educating the providers. As much as I can, I try to have my patients go into their provider visits with their compression and tell the provider, here's what I'm doing, and here's what I'm wearing, and here's what I'm using, because I found that to be the most effective way of spreading the word. And I go and do in-services to providers, but again, I think that they listen mostly to their patients. So with people that are articulate and good candidates, I coach them and say, this is going to help other people if you spread the word to your provider.
So we have one more question before I go over to Dr. Covington, and it sort of follows up. What are you doing about billing in this environment, Karen?
So that is a very, very good question. And I think a lot of it has to do with the particular facility. There are so many different insurance companies and so many different regulations. And so I can't give a blanket answer to that. And what I've had to do is I've had to diversify. I have had to go into doing home care because that is more billable than telehealth, but I still have telehealth patients, and our facility is going on faith at this point because there are so many changes that are happening, but yet we want to provide service. So that's a pretty individualized question for each provider, each state, each region. And I would just encourage people to get the education. I know that WebPT has a lot of webinars out there. There are other companies as well. And we need to be up to date in terms of what is reimbursable. And I encourage people to do that.
Thank you so much, Karen, for answering those questions. And Emily, if that adequately answered your question, then good. If not, please follow up. I want to go to the very first question that we got. Kathleen Judge posed this, and this is for you, Dr. Covington. Most telehealth visits require a video modality, and a lot of wound care centers don't have Zoom, Skype, iPads, or iPhones to allow the visualization of the wounds. Telephone visits only would be less desirable for wound assessment and management, obviously, in the early phases, as suggested. So how do you respond to that?
Yeah, great question. And I think, so there is no answer. And having pursued this with a variety of tools and resources, I mean, you can be as simple as an iPhone, right? So the challenge would be the HIPAA compliance. Zoom is HIPAA compliant, CarePICS, tissue analytics. A variety of tools and resources allow real-time video support, image capture, devices that allow planimetric measuring of the wound, so you can capture the wound's actual size that's measured by the device. If you don't have the video capability, at least you're having some interchange with the patient around, hey, let's talk. Can we find a way to capture an image and share it in a email format that is HIPAA compliant within your hospital system? It does create a time delay, but if I can see if I can see what the wound is, if I can see what the limb looks like, if I can get some basic data, some demographics around the patient's disease processes, most of the time I can piece together what's going on and at least start a care plan that's going to keep the patient out of trouble and get them to the right place at the right time.
Gotcha.
So hopefully that was helpful.
Yeah. If I can I jump in and just say that I've had patients send me pictures by email, and that has been helpful as well.
Very good. So you've both stirred a lot of interest among the group about at-home care and the huge need. One of our attendees has posed a question about liability concerns. I'll read her statement. There's a huge need for remote lymphedema care, as there are many patients who live in areas where there aren't any certified lymphedema therapists, and many patients who are homebound. I'm excited to hear this being discussed. I'm trying to implement remote lymphedema management in my community, and I see it as challenging, but very doable. But I'm still trying to understand the liability concerns. Thoughts?
I think it's about education. I think it's about making sure there's a really good foundation of understanding what we can and can't do, and then educating the patient about what we can and can't do. And I use that as a backbone to make sure that I'm covered.
Dr.
I would add, I would add, Brenda, that documentation is critical. Documentation in regard to Karen's point, what you can and can't see, the limitations of a two-dimensional image in a time when I'm not actually able to speak with the patient, but I'm looking at an email or a phone capture sometime after the original consultation. So I think it's education, documentation, and honestly, I think liability. People sue when they're unhappy. They're unhappy when they feel like the provider doesn't care about what they're doing or what the patient's going through, or they think that the provider hasn't done the right thing and the patient has suffered. So if you're educating and you're demonstrating compassion and you're documenting and you are explaining what you can and can't do in this new world, I think the likelihood of getting sued, it really drops way down.
That's a great point about documentation. And Nilma Santiago added that she contacted her malpractice insurance company and they added telemedicine e-visits to her coverage. So that was a helpful comment. So there was a lot of questions about what is HIPAA compliant. There was a question about, is Doxy HIPAA compliant? Angela Melton, who is asking that Zoom is HIPAA compliant, but is it or is it not, because it can be hacked? I know that after this seminar and tomorrow when we send you the recording, we'll be sending you a link to all the HIPAA compliant outlets that you can use. Is there anything that you'd like to say about Zoom and HIPAA compliance?
Well, so I guess there is some risk, but it represents itself as being a HIPAA compliant tool. We're using it right now in that situation and have had really no issue with it. I do have concerns, quite honestly, about when patients text me images to my phone, and when that occurs, I ask them not to, because the standard iPhone would not be HIPAA compliant. So understanding what your system, what your IDN has in regard to compliant tools, and again, there are so many out there, it's just making sure that you communicate efficiently and effectively, but also in a compliant manner, which really ties to the previous question about liability.
You know, when you raised the question or spoke to the fact that your parents were infirmed and older, and I know for myself, I'm dealing with an elderly mother, and taking her to doctor's appointments is almost a part-time job. And I don't say that snidely, it's my privilege to do it. But this COVID-19 situation has really forced a shift. I am doing my first telehealth visit for my mom with her pulmonologist next week. And so we are close to running out of time, and I want to make sure that we answer any remaining questions. Feel free to jump on the Q&A, but maybe as a broad brush overview or conclusive statement, Dr. Covington, what would you like to say to the audience today?
Yeah, thank you. And I think your situation, like mine, was or represents what's happening. And I think the reality is we've got to be more creative. We've got to be more thoughtful about how and where we're taking care of patients. As a physician, as a surgeon, it's fallen into the routine, quite frankly. Well, I'm in the office on Wednesday, and I'll see you next week. Well, I'll see you in 2 weeks. Well, why? Because it happens to be some convenient time factor that we can meet again. And that's not the answer. The answer is, I need to see you when I need to see you. I need to see the wound when there's a change or a concern. I need to see it maybe more frequently than once a week, or maybe less. And so my parting words would be, we have an opportunity thrust upon us to think differently about care venues, about how we touch patients, where and when we touch patients, and it's up to all of us to refocus and rethink about how we practice wound care and lymphedema management with those thoughts in mind.
Well said, and it has forced all of us to look at our business models differently. We were able to pivot very quickly, and instead of doing in-home deliveries of the Lympha Press, we're doing phone deliveries. The patients are having an excellent experience, and they're happy that they have the equipment to manage their conditions without violating the social distancing requirements right now. And it's a model that's working. So Karen, if you would give an overreaching, conclusive kind of statement before we wrap up today, what would you like to share with the audience?
Well, goodness, I would say that lymphedema is going to continue to be a problem into the future, and that this COVID-19 situation is an opportunity for us to look at expanding the models that we use in serving patients. And just as Dr. Covington said, when patients have needs, they need to reach out to us at their need level, as opposed to when it's convenient for us or when they have a scheduled visit. And so I think that the opportunity in this changing time is for us to examine our models of patient care. How can we adjust them so that they are more patient-centered, so that ultimately we can have better results?
That's it. And we so value the education that you've given us today. I am always reminded and feel so grateful that we offer a product that people can use at home at a time when they can't leave home. And so the hard work that our lymphedema therapists and our doctors and the medical community is doing isn't lost. We are able to maintain the momentum and the healing. I think my favorite quote is from one of our patients, Kelly Bell, who said, "You're not selling pumps, you're giving people their lives back." And what noble work that is to do. I'm going to wrap things up now. We appreciate all of you. It feels like we've answered all your questions. You're going to get this recorded webinar, links to resources, a link to a video about how to use Lympha Track. Good stuff coming. We have some upcoming webinars that you will also get links and descriptions about. And if there are no more parting shots or questions, we wish you a wonderful day and continue to thank you for the hard work that you're doing, taking care of people. We are in this together, making lives better for people. So thank you for joining us today. Have a great day.